Over to you.
Okay. Uh, Good evening, everyone. On the behalf of Research Society of Anesthesiology, I welcome everyone to the fortnightly webinar this time. And with permission of President Dr. Sir, I request him to grant permission to start the webinar with the proceedings.
Please, Dr. Swati,
Yeah.
carry on.
Continuing with the academic programs of the society, uh, this webinar has a very interesting theme, which will be discussing the controversies in neuroanesthesia, and we'll see have they been resolved. The webinar moderator is Dr. Ankur Khandelwal, and before I hand over the session to him to conduct for the next hour or so, I request Dr. Naveen Malhotra, sir, who is the president of the society, to please give some opening remarks and bless the audience.
Thank you, Dr. Swati. And Dr. Ankur, I'm very happy that you have taken the lead to conduct this webinar on behalf of RSAP Guwahati City Branch. And I'm very sure that you will be doing such programs regularly.
Thank you so
And
much.
as you committed, your topic is neuroanesthesia. And this is the part one of neuroanesthesia. And for next will be done by the Indore branch. That will be neuroanesthesia part two. And very interesting topics, as Dr. Swati was highlighting, we are lined up. And these are all pertaining to all anesthesiologists, whether it is nitrous oxide, ketamine, mannitol, hypertonic saline, and balanced salt solutions. These are all which are important to us in day-to-day clinical practice. And I'm really thankful to the moderators, the chairpersons, Dr. Manisha Katikar from Solapur and Dr. Harsh Chapra from Gurgaon for agreeing to our invitation to chair this session and carry it forward. And yes, no scientific program is complete without the eminent faculty. So I put on record deep sense of appreciations on behalf of Research Society of Anesthesiology to Dr. Sangeeta, Dr. Deep Sen Gupta, Dr. Pankaj Datta, and Dr. Kanchan. And I'm very sure that all the delegates will have a good time in the forthcoming deliberations over a period of an hour or so. I also take this opportunity to formally invite you to participate in different academic programs of Research Society of Anesthesiology. And you can apply for RSAP, GOCP editorial fellowship. You can participate in the youth conclave, and definitely we are going to have our annual conference next year in April in Indore. Thank you very much, and best wishes to all the speakers and chairs. Over to you, Dr. Swati.
Thank you so much, sir. Our webinars have the history of going houseful. I'll see that gradually more and more people are joining. But since it's time, I hand over the session to Dr. Ankur Khandelwal, and I request him to proceed with the session on controversies in neuroanesthesia. Over to you, Dr. Ankur.
Thank you so much, madam. Uh, and thank you, Naveen sir, for giving us the permission to start the meeting. It's all because of your initiatives. Uh, you take very well care of the entire society members, and the academic programs are going very fast, very nicely. All the sessions have been conducted very successfully with vast audiences, and we have been receiving tremendous feedbacks. And thank you for giving me the opportunity to start these sessions on neuroanesthesia. And today we have eminent faculties across the country who are very well known neuroanesthesiologists, and to deal with these topics which are known controversies in neuroanesthesia, we hope to find some solutions to the better ones after the end of this webinar. To moderate to chair this session, we have with us Dr. Manisha Katikar madam. She is a consultant anesthesiologist and intensivist, and working in the Balwant Institute of Neurosurgery in Solapur. Her key areas of interest are neuroanesthesia and neurocritical care. We thank you wholeheartedly, ma'am, for accepting our invitation and be a part of this webinar. We have another chairperson, Dr. RSACP sir from Medanta. He's a senior consultant and head of neuroanesthesia, neurocritical care. But however, due to certain commitments, he is still in the theater. But we hope that he joins us in some more minutes from now. But without further wasting any time, it's now my pleasure to invite our first speaker of the evening, Dr. Sangeeta RP, a very good friend and associate professor in neuroanesthesia, neurocritical care from NIMHANS, Bengaluru, former DM from NIMHANS. Her key areas of interest are neuromonitoring, perioperative, and acute brain injury. Thank you so much, Sangeeta. The stage is over to you. You can begin the proceedings.
Thank you, Dr. Ankur, for the kind introduction. Good evening, one and all. My sincere thanks to Dr. Ankur and the entire team for the opportunity to discuss a very important topic in today's webinar, which is controversies in neuroanesthesia. I am trying to share my screen, but I'm unable to. It says host disabled participant screen.
Yeah,
share.
I'll give you the rights. Just wait a second. Yeah, please retry now.
Yes, ma'am, trying. Okay, is my screen visible?
Yes, it is.
So this is an important topic. So we're going to discuss in the next 15 minutes as to whether nitrous oxide still has a role to play in neuroanesthesia. So as we all know, traditionally, nitrous oxide has been an integral component of general anesthesia for almost 200 years now. In the last 2 to 3 decades, however, due to clinical experience and extensive research that was conducted assessing the safety profile of nitrous oxide, various arguments and criticisms have been raised questioning the routine use of nitrous oxide in specifically neurosurgical patients. So in the next 15 minutes, I will take you through the different pros and cons of nitrous oxide use in neuroanesthesia. And for this, with due respect to the pioneers of nitrous oxide-based anesthesia, let's review a brief history of its introduction. Following this, let's review the unique properties that it has, which both favor and preclude its use in certain clinical scenarios. After this, let's review the current literature that is available, which both supports as well as condemns its use in different subset of neurosurgical population, with specific attention to the current controversial concerns. And based on these, by the end of today's presentation, let's try to arrive to a probable consensus, which can guide further use of nitrous oxide in neuroanesthesia. The discovery of nitrous oxide dates back to 18th century, and the credit of discovery of nitrous oxide goes to Mr. Joseph Priestley, who was an English chemist. Following this, it was Mr. Humphrey Davy who recognized its analgesic properties and its euphoria-producing properties, which he later published. Almost after 4 decades, following its first use by the dental surgeon called Mr. Horace Wells, it was Mr. Colton who established the role of nitrous oxide as an anesthetic agent. So this table summarizes the important properties of nitrous oxide, and what are more relevant for us are its mechanism of action, which is through antagonism of the NMDA receptor, that is the N-methyl D-aspartate receptor. The nitrous oxide has low anesthetic potency with a minimum alveolar concentration of around 105%, which is less compared to other potent inhalation anesthetic agents. Hence, it's co-administered along with other potent inhalation anesthetic agents. Its low blood gas partition coefficient of 0.47 facilitates its rapid equilibration of partial pressures between the alveoli as well as the pulmonary circulation. And this facilitates the rapid onset of anesthesia. Also, with high concentrations of nitrous oxide, there is rapid uptake of nitrous oxide as well as any co-administered inhalation anesthetic agent, which are referred to as the concentration effect and the second gas effect respectively. Also, due to rapid uptake of large volumes of nitrous oxide, there is a passive increase in the inspired ventilation, which is referred to as the augmented inflow effect. Also, during maintenance of anesthesia, nitrous oxide, since MAC is additive, it offers a sparing effect for co-administered inhalation anesthetic agents, and it helps in reduction of the magnitude of their cardiovascular and respiratory depressing property. During emergence from anesthesia, the same property causes rapid egress of nitrous oxide into the alveoli, causing dilution of alveoli, predisposing to diffusion hypoxia, which can be prevented by administering 100% oxygen at least for 5 minutes towards the end of surgery. And another important property of nitrous oxide, which is very favorable, is its rapid offset, which facilitates early postoperative neurological examination in our neurosurgical patients. So its pharmacodynamic profile is similar to other inhalational anesthetic agents, except that the magnitude of its cardiorespiratory suppression is lesser when compared to other inhalation anesthetic agents. A distinguishing feature of nitrous oxide from other inhalation agents is that it has an analgesic property which is mediated through both central and peripheral mechanism, that is through activation of opioid receptors in the periaqueductal gray matter, as well as activation of adrenoreceptors in the dorsal horn of spinal cord. Recurring criticisms raised against nitrous oxide is predominantly based on its effects on cerebral hemodynamics, in addition to other biochemical effects, which we will take up one after the other in the subsequent slides. So it's observed that in the presence of uncontrolled ventilation, due to its vasodilatory effect, nitrous oxide can increase cerebral blood volume, cerebral blood flow, and cerebral metabolic rate. It can also impair cerebral autoregulation and can compromise intracranial compliance. Further, in the presence of background anesthetic and the degree and varying degrees of ventilation, the magnitude of these changes can vary. That is, in the presence of intravenous agents such as propofol and through institution of hyperventilation, we can limit the increase in cerebral blood flow and cerebral blood volume. A recent review of clinical trials demonstrates that in the presence of background anesthetic, the magnitude of these effects and even the direction may be variable, and none of these studies could demonstrate any major impact of nitrous oxide on the operating conditions of intracranial surgery. So what are the other concerns of nitrous oxide-based anesthesia? Solubility of nitrous oxide far exceeds that of nitrogen. This facilitates the entrance of nitrous oxide into closed spaces, which far exceeds the exit of nitrogen from closed spaces to the bloodstream. So this can lead to rapid increase in the volume of compliant cavities and rapid increase in the pressure of non-compliant ones. This can have significant clinical implications in the form of bowel distension, intraocular gas expansion, middle ear pressure changes, and worsening of pneumothorax. What is of more concern to us in neuroanesthesia is its ability to worsen or cause pneumocephalus as well as air embolism. So various clinical reports have reported have attributed the occurrence of pneumocephalus to use of nitrous oxide during surgery, which is more common in those patients who've undergone previous cranial or spinal surgeries and surgeries involving breach of dura mater. It's also seen to be common in patients with traumatic head injury and those with pre-existing pneumosyphilis. Also, studies indicate that this intracranial air can persist as long as 3 weeks post-surgery. Despite this evidence, for those of who want to adhere to use of nitrous oxide in neurosurgery, it's advised that they have to wait for at least 6 to 8 weeks after open dura surgery before using nitrous oxide. Even following first-time craniotomy, there are multiple case reports attributing postoperative pneumocephalus to nitrous oxide. Its advocates, however, can argue, stating that nitrous oxide in cases where nitrous oxide was not used, pneumocephalus has still occurred. And their argument is that there can be alternate mechanisms to causation of pneumocephalus in these patients. A temperature effect on gas volumes, the inverted pop bottle effect, and gravitational effects on intracranial volume dynamics can cause adverse effects misattributed to nitrous oxide, is their argument. But irrespective of which side one wants to take, it is imperative to discontinue nitrous oxide when there is evidence of raised intracranial pressure and upon detection of venous air embolism, which we know is common during sitting craniotomies. Another important concern is nitrous oxide-induced postoperative nausea, vomiting. This is of more concern in patients undergoing neurosurgery because this can confound raised ICP-induced post-op nausea, vomiting, which can occur due to acute intracranial complications such as surgical site hematoma and so on. Though the exact mechanism for this remains to be elucidated, middle ear pressure changes, bowel distension, and dopaminergic neuronal activation are the possible mechanisms. Also, recent studies indicate that the predisposition to nitrous induced post-operative nausea, vomiting depends on the length of exposure to nitrous oxide. That is, the risk ratio of post-op nausea, vomiting increases by 20% per hour of exposure, beginning at 45 minutes after initiation. And studies also say that the risk remains the same even with antiemetic prophylaxis. So during neurosurgery, when there is monitoring of electrophysiological parameters, which includes either electroencephalogram or evoked potential monitoring, nitrous oxide can cause activation of EEG and subsequent increase in bispectral index can be expected. So titration of anesthesia using this index when nitrous oxide is being used can cause inappropriately deep anesthesia. Nitrous can also decrease the amplitude of cerebral electrophysiological signals and hinder optimal baseline tracings, dissuading its use when crucial electrophysiological monitoring is required to guide the course of surgery. Another dreaded concern complication is its ability to cause adverse biochemical effects. So what happens is nitrous oxide causes irreversible oxidation of cobalt atom of vitamin B12, which acts as a cofactor for two important mechanisms. So it impairs the enzymatic function of two enzymes, which is methionine and thymidinate synthase, hence disrupting myelin synthesis as well as DNA synthesis. So what is the repercussion of this? This can lead to severe complications such as hyperhomocystinemia, which in turn can predispose to platelet aggregation, vasoconstriction, impaired endothelial function, and hence to stroke as well as myocardial infarction. Also, patients can develop megaloblastic anemia and neurological impairment, which can range from transient mild paresthesia to severe subacute combined degeneration of the cord. At the cellular level, this can cause neuronal mitochondrial swelling and apoptosis, and hence neurotoxicity, along with neuronal myelination defects, polyneuropathy, dementia, and thrombosis. Also, it's observed that this can lead to permanent disabilities and life-threatening consequences, specifically in those with genetic predisposition, that is genetic disorders of folate metabolism, in addition to patients with vitamin B12 deficiency. With respect to occupational hazard, there is documented evidence for risk of miscarriage and reduced fertility among female theatre workers. The question is, such chronic repeated exposure within a short time frame, can it predispose to such adverse biochemical effects? Some may argue that these apprehensions may be unfounded in the era of anesthesia scavenging system. Nevertheless, there are specific guidelines by the NIOSH, which is the National Institute for Occupational Safety and Health, which has imposed clear occupational exposure limits, that is 25 to 100 ppm, and which confirms its hazardous potential. And in most countries, nitrous oxide is now listed in the Hazardous Substances Ordinance. Nitrous oxide is currently the leading cause of ozone depletion and has a global warming potential, which is almost 200 times that of carbon dioxide. One may argue that anesthesia accounts for less than 1% of total nitrous oxide emissions, which is further lower with use of low-flow systems. But the question is, why even contribute to that? The potential for administration of a hypoxic mixture can be avoided by use of hypoxic guard or oxygen analyzer. The nitrous oxide has a documented potential to be teratogenic, which is well established in mammalian models and less established in humans. Nitrous oxide, as we know, is favored for labor analgesia. However, there is a good argument for nitrous oxide-free anesthesia during the first trimester of pregnancy. So let's look at two landmark trials which have tried to assess the side effect safety profile of nitrous oxide. So the first one is the ENIGMA trial, which randomized 2,000 patients undergoing non-cardiac surgery lasting for more than 2 hours to either nitrous oxide-based or nitrous oxide-free anesthesia. And here they found that nitrous oxide was associated with increased long-term risk of myocardial infarction. A subsequently performed Enigma 2 trial, which randomized 7,000 patients into similar groups, found that nitrous oxide did not increase the risk of death or cardiovascular complications, but definitely there was an increase in the incidence of severe nausea, vomiting. So now these two studies have enrolled a heterogeneous population. So do these effects of nitrous oxide influence the functional outcome after neurosurgery? So to address this question, a subgroup post hoc analysis of the Enigma 1 and Enigma 2 trial was performed. So specifically neurosurgical patients were identified. They were about 830 patients, and in them an analysis was performed to assess for risk of post-operative complications. So the study demonstrated that nitrous oxide did not increase the risk of post-operative complications or prolonged the length of hospital stay in the neurosurgical cohort. Now let's look at the different sub-diagnoses among neurosurgical patients. Now first, coming to patients who underwent intracranial aneurysm surgeries, there were about 1,000 patients who were enrolled in the landmark IHAST trial, which assessed the efficacy of hypothermia in these patients. So here it was found that when patients received nitrous oxide, it did not increase the risk of development of delayed ischemic neurological deficit. However, subsequently, a more focused analysis of these neurosurgical patients of only those who underwent temporary arterial occlusion. So these patients were chosen and analyzed separately, and in them, it was found that there was a greater risk of delayed ischemic neurological deficits if nitrous oxide was administered. But however, there was no evidence of detriment to long-term gross neurologic or neuropsychological outcome, indicating that nitrous oxide may influence the short-term outcome, if not the long-term neurological morbidity. So this was another landmark trial called the GALA trial, which compared general anesthesia with local anesthesia in patients who underwent carotid surgery. So only those patients who underwent general anesthesia, their information was extracted, and they were assessed if the chances of vascular events such as death, stroke, and myocardial infarction was high in those who received nitrous oxide. Though here we see that it was slightly high, which was 5.2% among patients who received nitrous oxide versus those who didn't. The authors state that this could be because of a greater prevalence of vascular risk factors itself in the nitrous group to start with. So what is the role of nitrous oxide in patients with stroke? So this is a recent review of multiple studies involving both preclinical as well as clinical studies. So in this study demonstrated that following middle cerebral artery occlusion, nitrous oxide, when administered within first 2 hours following the MCA occlusion, it had neuroprotective effects in the form of reduction of cortical ischemic neuronal death by 70% and a decrease in NMDA-induced calcium influx by 30%. So this was found to be time sensitive with a relatively narrow therapeutic window. So what happened after 3 hours? Beyond 3 hours, when it was administered, it was found that nitrous oxide increased the infarct volume, appearing to be neurotoxic. And if you can have a close look at these human trials, we can see that they've reported a derangement of cerebral autoregulation with use of nitrous oxide. And the second study has clearly stated that nitrous oxide should be avoided in patients with severe intracranial hypertension. So it's interesting to note that in the recent years, there have been many studies performed to revisit and examine the safety profile of nitrous oxide in neurosurgery. Two post hoc analysis of the Enigma 2 trial revealed that nitrous oxide did not have any impact on chronic post-surgical pain, and nor did it worsen cognition scores, especially the memory and processing speed components of cognition. But it's important to note that majority of the study population was heterogeneous, and the neurosurgical population representation was only 7%. This was one of the most recent RCTs I could find, which was performed in cerebellopontine tumor surgeries. And the investigators here could find neither an increased length of intensive care unit or hospital stay, nor could they find it affecting complications and conditions at discharge. But it's important to note that this study was performed only in good grade patients with questionable extrapolation to poor grade patients presenting with raised intracranial pressure. So why does the enthusiasm for use of nitrous oxide still persist? So if the answer to this question is going to be like, we've been using nitrous for quite some time now and nothing really happens, then I think it's time to reconsider the real medical need for the use of nitrous oxide as an anesthetic when there is access to well-tolerated short to ultra-short acting anesthetic drugs as alternatives. And in such scenario, is there a real need to accept the proven adverse effects? And in the current era of enhanced recovery after surgery, where the trend is shifting towards more of minimally invasive surgeries and daycare neurosurgeries, I wouldn't want my patient to wake up with post-operative nausea, vomiting, right? Especially when there is access to safer alternatives like, say, dexmedetomidine, dexamethasone, or one can also consider using gabapentinoids, among the rest. So beyond the confines of our theaters, nitrous oxide is currently in the news for wrong reasons, which is for recreational nitrous oxide abuse, which has been reported to cause various dreaded complications such as ischemic stroke, central venous thrombosis, subacute combined degeneration. And there have been so many reports in the last 2 years itself. So the question is, can a repeated exposure, say occupational exposure, can it also present a similar predisposition to development of these similar complications? So are we still in a state of equipoise? I don't think so. I think we've moved beyond that. And it's high time we start questioning ourselves as to whether it is still justified to continue using a weak analgesic, which has no clear advantage compared with modern alternatives, which does not significantly add to the quality or efficacy of contemporary anesthesia practice, whose safety profile at the very least is currently doubtful. So to summarize, respect the clear contraindications in the form of pneumocephalus, venous air embolism, folate or vitamin B12 deficiency, and in those patients with a higher risk of postoperative nausea, vomiting. It's important to assess the risk-benefit ratio and opt for the decision that maximally benefits the patient. And during decision-making, it's extremely important to keep in mind that it's always better to err on the side of caution. Pragmatic avoidance of nitrous oxide in neurosurgical patients is the way forward until challenged by negative studies, which not only say that nitrous oxide is non-inferior to alternatives in terms of side effect profile, but if it's able to prove that it has added therapeutic benefit, that would be even better. So until then, meanwhile, opt for safer alternatives such as total intravenous anesthesia and other anesthetic adjuncts, and stay committed to not doing harm to patients. So the answer to the question as to whether nitrous still has a role to play in neuroanesthesia, I think currently the answer is no, until we are able to create robust evidence which challenges the belief that nitrous oxide can do more harm than good. Thank you.
Thank you so much, Dr. Sangeeta, for this fantastic talk. You have laid down all the scientific evidences, including the recent ones. This would have been very, very helpful. I'm sure there are proponents of nitrous oxide as well as opponents of nitrous oxide. I'm sure there will be a lot of queries in the chat box. We'll take these queries at the end of all the talks. Till then, enjoy the rest of the talks.
Thank you.
It's my pleasure to invite our second speaker of the evening, Dr. Deep Sen Gupta. Dr. Deep Sen Gupta is working as a consultant neuroanesthesiologist in AIG Hospitals, Hyderabad, a former DM from AIMS, New Delhi, a very hardworking guy. He'll be speaking on the topic ketamine. Again, a very controversial topic. Ketamine in neuroanesthesia, should its use be on or off, seasonal or regular? Over to you, Dr. Deep.
Good evening, respected chairpersons, esteemed teachers, and dear colleagues. I am sincerely grateful to RSACP and Dr. Ankur sir for giving me this opportunity in this erudite platform. To start with the presentation. The screen sharing is not happening.
You are the co-host. You'll be able to share. Can you recheck?
I'll try, ma'am. One. No, it's not happening.
In your participants, can you see yourself as a co-host? Can you confirm that?
Yeah, he's being shown as a co-host.
Yeah, then you should be able to share.
Can we ask him to log out once and get back to the session?
I'll do that.
Yeah.
Somehow it's not showing any screen sharing. This is showing one participant at a time and multiple can share simultaneously.
No one else is sharing.
Yeah. So all the co-hosts in the settings can share. Dr. Ankur, can we do one thing? Maybe Dr. Deep can rejoin the meeting.
Yeah, yeah.
Meanwhile, we can take questions for Dr. Sangeeta to maintain the continuity.
Or can we invite the third speaker and then Dr. Deep can speak
Yeah.
after him?
Yeah, that's fine too. If the third
Dr.
speaker is
Kostav,
ready.
are you there? Dr. Kostav?
Yeah. Am I audible?
Yeah, Dr. Kostav, you are audible.
Yeah, just let me share the screen. Is my screen visible?
Yes,
Yeah,
it
it's
is.
visible. Ladies and gentlemen, again, it's my pleasure to invite Dr. Kostav Datta, very, very close friend of mine, a colleague. He is a consultant neuroanesthesia and neurocritical care at Dr. P.K. Saha Hospitals in North Bengal. A former DM from Nimhans, Bengaluru. He'll be taking us through the topic mannitol or hypertonic saline in neuroanesthesia and neurocritical care. Over to you, Dr. Kostav.
Thank you, Dr. Ankur, for the kind introduction. So let's begin. My topic is mannitol versus hypertonic saline. So the debate simply between salt and sugar. We know the structure of mannitol. Mannitol is basically a polyhydroxy sugar alcohol, and the hypertonic saline, the commonly used ones that in our setting is 3%. Although the concentration ranges from 3%, 5%, even 7.5% to 23.4%, but most of those are not available for use in our country. So what we commonly use is a 3% hypertonic saline. And here, I would also like to tell you about the osmolarity, because both of these agents are used as hyperosmolar agents. The main goal is, in case of any condition causing raised intracranial pressure, the goal is to reduce the intracranial pressure by creating an osmotic gradient. And both these agents are hyperosmolar agents. The osmolarity of mannitol is around 1098, and that of 3% NS is 1026 millimole per liter. So first, let us see the subtle differences between mannitol and hypertonic saline. So the primary mechanism is more or less similar. Both of them create an osmotic gradient across the blood-brain barrier, and that causes a rapid shift of fluid from the brain into the intravascular space. And the duration of effect for mannitol is around 6 hours, whereas for hypertonic saline is also 4 to 6 hours. The secondary mechanisms, what mannitol does is it also causes cerebral vasoconstriction. It decreases the blood viscosity and changes the blood rheology. And this in turn improves the cerebral blood flow. We all know that in case of raised intracranial pressure, the blood flow gets compromised because the raised intracranial pressure. So the goal is to increase the in the cerebral blood flow and decrease the ICP. So mannitol helps in increasing the cerebral blood flow by changing the blood rheology. And the hypertonic saline has been shown to have some immunomodulatory and anti-inflammatory effects, which are very beneficial in cases of trauma. And this also helps to bring down the secondary brain injury that occurs after a primary injury. Next, coming to the hemodynamic effects, the differences between the two. The mannitol it increases the intravascular volume immediately, and then it causes brisk osmotic diuresis. But the caution here to be taken is it can cause hypovolemia and hypotension if fluid resuscitation is not ongoing simultaneously. Whereas hypertonic saline, it expands the intravascular volume and it maintains the mean arterial pressure. So this beneficial effect of hypertonic saline comes handy in more in a lot of situations where we cannot use mannitol, and then in such situations hypertonic saline can be used. Now, one more important difference is the reflection coefficient. So what is reflection coefficient? So this is basically the permeability through across the blood-brain barrier. So it is seen that the reflection coefficient of mannitol is 0.9, which is almost impermeable, assuming the blood-brain barrier is intact. Whereas in case of hypertonic saline, it is 1. That is, it's completely impermeable. That is, no hypertonic saline from the plasma will cross the blood-brain barrier. This becomes useful because when we use mannitol continuously over a long period of time, it is seen that it develops tolerance and there is a rebound, chance of a rebound edema. That's the reason mannitol cannot be used for a very prolonged period of time, whereas hypertonic saline infusions can be continued. I think all of us are aware, and especially if there are PG students attending this webinar, they should be aware that there is something called a Monroe-Kelly doctrine. So we know that the skull is a closed cavity, and there are components like the brain tissue, the blood parenchyma, the fluid, the CS. So if there is an increase in component of one component, there should be a compensatory decrease in the other component to maintain the intracranial pressure. So initially this is maintained. However, when this is cannot be maintained, then that leads to rapid rise in ICP, and then there is a risk of ischemia and impending herniation. Okay. So what are the indications of hyperosmolar therapy where we can use mannitol or hypertonic saline? So we all know traumatic brain injury is the most common cause, contusions, subdural hematoma. Here, one important thing is we do not use hyperosmolar agents in case of extradural hematoma because, of course, it is outside the brain parenchyma. So it can, if you use hyperosmolar therapy in such cases, it can in fact lead to increase in the size of the hematoma. Okay. Next is the intracerebral hemorrhage, then malignant cerebral infarctions following an acute ischemic infarct, especially in malignant MCA infarctions, and then other cases of supratentorial lesions, subarachnoid hemorrhage, and acute liver failure. Okay. But again, just to note that the edema because of tumors is mostly vasogenic, where the role of mannitol or hyposmolar is limited. There we use steroids. So what is the doses? So mannitol boluses can be given 0.5 to 1 gram per kg, IV in 3 or 4 divided doses or even more. Even we can go up to a dose of 1.5 grams per kg per IV. And 3% we can use boluses in 2.5 to 5.5 to 5 ml per kg body weight, and infusions can be run at 0.1 ml to 1 ml per kg per hour infusions. Important difference is mannitol cannot be used as an infusion. It is normally given as boluses over 15 to 20 minutes. The common adverse events seen with the use of mannitol is acute kidney injury. This is one of the most common side effect that is very troublesome, and especially patients with a raised creatinine, we usually stop mannitol and switch over to hypertonic saline. Then dehydration if fluids are not going on, hypotension, hemodynamic instability, electrolyte imbalances, and then the fifth one is the rebound increased in ICP. As I said, after prolonged use, if you use mannitol beyond the third or fourth day, then we see that the brain tissue develops a idiogenic osmosis. That means there's a reverse shift. So the osmotic shift is reversed. So this increase can in turn increase the intracranial pressure, and there will be a tolerance to the effect of mannitol. Whereas hypertonic saline, the most common side effect is fluid overload. So it should be used cautiously in patients with heart disease and especially patients with heart failure, and it can cause pulmonary edema. And if there is an hyponatremia at presentation, and rapid correction of sodium with hypertonic saline can again cause osmotic demyelination syndrome, again a dreaded complication. And then metabolic abnormalities like hyperchloremic metabolic acidosis and hyperoncotic hemolysis. So what do the guidelines or recommend, or which agent is preferred? So the Brain Trauma Foundation, we lays down the guidelines for the different guidelines and recommendation based on different studies. And according to the Brain Trauma Foundation supported CBIC guidelines for traumatic brain injury algorithm. So what they say is that hypertonic saline can be used as a tier 1 therapy for by intermittent boluses, along with the other therapy for decreasing the raised ICP, like CSF drainage, placement of an EVD, and when we the patient does not respond to such therapy, we go to tier 3 therapies, which is basically decompressive craniectomy and sometimes even thiopentol coma. So here, the important what I wanted to highlight was that when we use these hypertonic agents, so what is the allowable sodium levels or osmolality that we usually have? So what the guidelines recommend is the serum sodium should not cross more than 155, and the osmolality should be maintained below 320 milliequivalent. Okay? Otherwise, again, it can cause severe metabolic and renal derangements. So then let us begin the debate and see the various studies, what they talk about specifically about mannitol versus hypertonic saline. So this is a comparison of hypertonic saline and mannitol on intraoperative brain relaxations in patients with raised intracranial pressure during supratentorial tumor resections. So it is a randomized controlled trial, and it is conducted by from PGI Chandigarh, as well as some authors are from Ludhiana. So this was a prospective double-blind study that was conducted on 30 patients, and each they were divided into two groups. One received mannitol, the other received hypertonic saline during intra period. So what they found was the intraoperative brain relaxation was comparable between the two groups, but there was a statistically significant difference in the mean arterial pressure. The mean arterial pressure was definitely better maintained with hypertonic saline, and there was also a transient increase in serum sodium concentration. But what they have concluded is this usually returned to normal within the next 2 days. And both the agents provided adequate intraoperative brain relaxation. So what we can infer from this study is, as far as ICP or decreasing the intracranial pressure is concerned, both agents are equally effective. But what the hypertonic saline does is, it has a superior, it has an advantage as it maintains the hemodynamic stability. That is, it does not cause a fall in the mean arterial pressure. So they advocate the use of hypertonic saline over mannitol in such cases. Next, this is a clinical outcome study of hypertonic saline versus mannitol among children with traumatic brain injury. So this was a multi-center cohort study conducted from 2018 to 2022 across 3 continents, that is Asia, Latin America, and Europe, and around 28 intensive care units participated in it. So what they wanted to study was whether among children with moderate to severe traumatic brain injury, is the use of 3% saline associated with better survival and functional outcomes compared to 20% mannitol. So what they found was that there was no group differences in mortality, discharge, or the pediatric outcome scales. But what they suggested was hypertonic saline was not associated with increased survival or improved functional outcome. This is again different from what the guidelines suggest, because the CBIC guidelines again recommend that hypertonic saline may be used in children in case of traumatic brain injury. However, this recent study clearly says that there's no added advantage as far as survival is concerned or improved functional outcome when we use hypertonic saline over mannitol. Then this is again a review article whether hypertonic saline be considered as a treatment of primary treatment for intracranial hypertension. So here again, both hypertonic saline and mannitol have been seen to reduce intracranial pressure by creating an osmotic gradient. However, the hypertonic saline does not induce diuresis or significantly lower blood pressure, making it more favorable for maintaining cerebral perfusion. So decreasing ICP is one aspect, whereas the maintaining cerebral perfusion is another important aspect. And in this regard, definitely hypertonic saline is more beneficial than mannitol. And one more advantage that hypertonic saline has, it does not cause rebound edema and carries a lower risk of renal injury than mannitol. Then again, there is a systematic review and meta-analysis of hypertonic saline and mannitol in patients with traumatic brain injury. So here again, they wanted to compare the differences between the two agents. Here they again found that there was no significant difference in the decrease of ICP and the onset time between the two groups, but the only difference was the duration of effect in reducing intracranial pressure was higher with the use of hypertonic saline. So conclusion is both are effective in decreasing ICP, but 3% saline has a more sustained effect on intracranial pressure and can effectively increase cerebral perfusion pressure. So mannitol, then why do we still use mannitol? Because mannitol is traditionally considered, because of its a long history, we have been using it. Our predecessors, our teachers have been using it for a long time. We are familiar with the doses. We are familiar. It's easily available, and it causes a fair reduction in the IC. However, there's a mixed results in clinical trials, specifically concerning the hemodynamic instability and adverse effects like renal injury. However, this can always be mitigated if you have, give adequate fluids and ensure that the osmolarity is daily checked to prevent renal injury. Again, hypertonic saline, the advantages, the effect is more sustained, it maintains hemodynamic stability, the cerebral perfusion pressure is maintained, and but however, most of the studies have not found any added survival or improved functional outcome, even with hypertonic saline. Okay, and one more advantage is hypertonic saline does not develop tolerance, unlike mannitol. So, do we have a formal recommendation then? Well, the BTF fourth edition do not support the use of any specific agent. So there's no formal recommendation and there's no evidence to support the use of any specific hyperosmolar medications in patients with severe traumatic brain injury. But in recent pediatric trauma guidelines, they recommend hypertonic saline over mannitol in traumatic brain injury. So final word, both hypertonic saline and mannitol are effective in reducing ICP. But what we commonly use, or what we commonly see, is a combination of agents. In my practice or the institutes where I work, we have used both the agents. Sometimes this helps to decrease the dose of both the agents, thus decreasing the side effects. And again, the choice of agents driven by the safety profile, the patient's renal profile, the hydration status, the electrolyte status, and again other patient-specific factors. If a patient has a cardiac issue, then of course better to avoid hypertonic saline. And hypertonic saline, as I said, does not cause rebound edema and carries a lower risk of renal injury than mannitol. Here again, what is important to notice, the renal injury because of hypertonic saline is caused mostly because of the chloride load. Okay, so if the chloride is in check, then we can definitely use hypertonic saline in patients with AKI. And pediatric brain trauma guidelines recommend hypertonic saline over mannitol. Thank you. Thank you for giving me this opportunity. And thank you once again, the organizers.
Thank you, Dr. Costa. Thank you, Dr. Costa, for this fantastic presentation. You have equally weighted hypertonic saline and mannitol as far as scientific evidence is concerned. But I'm sure there would be a lot of queries again regarding the pros and cons of hypertonic saline and mannitol each. Let us wait for the queries in the chat box. Till then, you enjoy the rest of the talks. May I now again invite Dr. Deep Sen Gupta to start his presentation on ketamine. Dr. Deep, are you there?
Yes, sir.
Yeah, can you share your screen, please?
Yeah, doing that, sir.
Dr. Deep is working as consultant neuroanesthesiologist in Asian Institute of Gastroenterology, Hyderabad, a former DM from AIIMS, New Delhi.
Is there a problem, Dr. Deep?
Yes, ma'am. Again, it's getting stuck. Just give me 1 sec, ma'am.
Yeah.
Dr. Kanchan, are you there?
Can you hear me?
Yeah, Dr. Kanchan. It's
Yes.
fine. Yeah, Dr. Deep, your screen is visible.
Yeah.
Yeah.
Awesome.
Right. Okay. So good evening once again to all the respected chairpersons, esteemed teachers, and dear colleagues. And I'm sincerely grateful to RSACP and Dr. Ankur sir for giving me this opportunity in this erudite platform. Coming to the topic, ketamine seasonal or regular. Uh, let's dive into the interesting history of ketamine, how it rose into the common consciousness in the medical field. the ketamine, the rise. So it was first synthesized in the year 1962, and it was termed as compound C1-581. It was later renamed as ketamine. The first clinical study was done by Dr. Edward and Dr. Gwenter. It was done on 20 male prisoners for the first time, and they found very interesting finding that though these prisoners were able to protect their airway, they were appearing conscious, but they were not responding to sensory stimuli. And from there on, the further work led to the coining of the term dissociative anesthesia, which was associated with ketamine. Eventually, FDA gave its approval in 1970 for general anesthetic use, and it was extensively used in the Vietnam War for surgical anesthesia. Ketamine, the fall. How did it fell out of recognition? So there were concerns which were raised about the sense of delirium which ketamine induced. It finally led to a decline in its use as a human anesthetic. In sub-anesthetic doses, it was found that it has a psychedelic effect, and the recreational misuse started happening, which was first reported officially in the year 1971. It was commonly known as a club drug or rave drug with various interesting street names like Vitamin K, Kit Kat, K-Land, K-Hole, Cadvalium, and Special K. FDA then made it a Schedule 3 drug, and it slowly fell out of favor. Coming to the resurgence, how did ketamine again came back into the formal recognition? So more depth into the mechanism of action, the insight which we gained and its efficacy gave this resurgence to ketamine. It has a broad neuropharmacological pleiotropism, action on multiple receptors with various beneficial effects. And there is a slew of evidence which disproved its role in rise in ICP, which was the most prominent factor which led to its downfall. Multiple new avenues have opened up for ketamine with effects in epilepsy, stroke, migraine, which we will deal later. A brief pharmacological effect. So it's a phencyclidine derivative. There are two optical enantiomers, S plus and R minus. S-ketamine particularly is of interest to us. It acts on GLUT N2A subunit, which leads to hypnosis, and GLU N2B subunit, which leads to analgesia. These are glutaminergic receptors. Commercially, what we get is a racemic mixture of both S-ketamine and R-ketamine. S-ketamine particularly is of interest because it has a potent antidepressant effect. It rapidly reduces suicidal ideation. It is FDA approved in adults with major depressive disorder. It's a potent analgesic. It deters the onset of chronic pain, reduces opioid dependence post-operatively. It is safe and effective in pediatric patients, and it reduces the incidence of post-op agitation and delirium. All these are compared to the R-ketamine enantiomer. Interesting bioavailability with multiple routes which it can be administered. Intravenous, it has 100% bioavailability. IM 90%, subsequently oral, rectal, and intranasal 17, 25, and 50% respectively. Intranasal is more important because it was used for recreational purposes also. It's a lipid-soluble, low plasma protein binding drug with a distribution half-life of 10 to 15 minutes with a large volume of distribution of 2.2 liters per kg. It is primarily metabolized by cytochrome system P453A4. The most important and active metabolite is norketamine, which is 1/3 anesthetic potency. It is 90% excreted in urine with a half-life of 2 to 3 hours. This is the NMDA receptor. So NMDA receptor, as I said, the most important part which we have to consider here is it has two domain or binding sites. The phencyclidine site, which decreases the duration of channel opening, and the hydrophobic domain, which decreases the frequency of channel opening. NMDA receptor per se, it is the most abundant excitatory receptor in the central nervous system, with glutamate being its principal ligand and co-agonist is glycine. It is partially inhibited by magnesium. The neuroprotective role is against the glutamate-induced neurotoxicity. As glutamate dissociates and closure of the channel occurs, ketamine remains trapped within the channel and it continues the channel blockade. Fairly speaking, NMDA antagonism has four very clinical significant factors which we are of interest to us. It is amnesia, psychosensory property, analgesia, and neuroprotection. It has its other pleiotropic actions on multiple other receptors. It binds to all opioid receptors with the highest affinity to mu receptor, which plays a role in the regulation of central antinociceptive mechanism. GABA receptors it binds to in spinal cord, which potentiates the inhibitory effect of GABA. Muscarinic receptors, it's dose-dependent blockade. It primarily leads to peripheral anticholinergic action, which leads to bronchodilation. The monoaminergic receptors, it results failed reuptake of monoamine, higher circulating levels of norepinephrine, dopamine, and serotonin, and which this action of it is helpful in depression, antidepressant mechanism of ketamine, and it has central sympathomimetic properties as well. And blockade of HCN channels. Its cortical neuron electroresponsiveness alteration happens because of this HCN channel blockade, which contributes to hypnotic dissociative state. So tackling one controversy one by one. So first, the rise in ICP. So this concept and this myth primarily started with a series of 6 studies in the 1970s. There were a bunch of case reports and small case control studies, and they reported a direct association between ketamine and rise in ICP. All these studies have one or two confounders, most important being abnormal CSF pathways like aqueductal stenosis and obstructive hydrocephalus. And none of these studies they directly evaluated the effect of ketamine in patients with traumatic brain injury. These are the list of studies which led to the downfall of ketamine and to the rise of this myth that ketamine increases the ICP. Very new studies have come, multiple new evidences have come. This is one systematic review which was published in 2022. They did 625 study selection, which out of them 52 met their inclusion and exclusion criteria. And they primarily said that regarding ICP, there is no pathological rise in ICP. It prevents the cuff reflex. It decreases the ICP value in a short period of time. The ICP was median time of decrease, it was 7.8 mmHg in pediatric population, while there were no adverse events related to its rise. Regarding cerebral perfusion pressure, they reported a rise by 3.9 millimeters of mercury without any adverse effects. MAP and heart rate, no significant variation in either was reported. EEG, it significantly reduced cortical spreading depolarization and also led to a dose-dependent burst suppression. Both are very beneficial effects. And in ventilation, they found bronchodilatory effects with ketamine. This is another recently published retrospective multicentric study. Here they analyzed 841 subjects and they concluded that ketamine administration was not associated with increased mortality or disability, and there were fewer instances of elevated ICP despite being administered to more severely injured subjects. Again, there's a list of prospective RCTs with ketamine and its effect on ICP. Mayberg et al., it was a prospective trial. They found that it was a ICP, though small, but statistically significant decrease in ICP after ketamine administration. And similar findings were found by different authors. Moving to the other applied aspects in ketamine, ketamine has a newfound role in migraine treatment. Various studies have come up. Primarily, it is indicated in medically refractory migraine. So the point to be noted is that it's not the first line of drug, but for medically refractory ones, ketamine can be considered. Possible mechanism of action. Prolonged infusion leads to accumulation of norketamine. The inhibition of calcium-mediated release of CGRP plays an important role in central nociception and blocking of the cortical spreading depolarization by its anti-glutamate action. The doses recommended being intranasal ketamine at 0.1 to 0.2 mg per kg per dose up to 5 doses, or intravenous infusion of 5 to 10 milligrams per hour up to 1 mg per kg per hour. Some of the studies which report the beneficial effect of ketamine in migraine, they have their own different doses, and all of them had found either marked difference or short-term relief, with only one study found no such difference done by Hutchison in 2018. Ketamine's role in status epilepticus. So again, its role is primarily in refractory status epilepticus. How does it work? It works by downregulation of GABA receptors. It leads to the failure of anti-epileptic drugs, sustained activation of NMDA receptors, and subsequent glutamate toxicity. Now, this is the mechanism how which the refractory component of the status epilepticus kick in. So ketamine, with its anti-glutaminergic action, has a role in refractory status epilepticus. Once a study done by Gaspard et al., it's a multi-center retrospective study. It showed that ketamine is safe and efficacious agent in RSE. They used very high doses of 10 mg per kg per hour without any adverse event. Another meta-analysis done by Rosati et al., it was done in 238 patients, and they found that 70% patients achieved refractory status epilepticus control with ketamine. The dose they used was 0.07 to 15 mg per kg per hour. Coming to the available evidence, so NCSI guidelines in 2012, they acknowledged ketamine as an emergence emerging therapeutic option. But very recently, the American Epilepsy Society, they have not given sufficient credence to the available evidence, and therefore they have not recommended ketamine in status epilepticus. Neither they have recommended nor they have gone against it. The role of ketamine in stroke. So diffuse cerebral ischemia, cerebral vasospasm, neuroinflammation, microthrombosis, and the keyword cortical spreading depolarization. Now, DCI has an interplay of all these mechanisms. Ketamine primarily ameliorates the cortical spreading depolarization component. It also increases cerebral blood flow, increases cerebral perfusion pressure, and it reduces the glutamate mediated neuroinflammation. One such study by Vonderburley, it was a retrospective study, they found that SH patients who received ketamine for sedation, they had a decreased incidence of DCI in the ketamine group. It was 7.3 versus 25%, which was statistically significant. They titrated their ketamine for sedation to a RAS score of -4 with a maximum doses of 500 mg per hour. There are two interesting trials which are going on. Once the results come in, we will have a further understanding of its role in stroke. One is KIND trial, ketamine in neurological deficit. They are using subanesthetic ketamine infusions in SAH patients, and their primary objective is to assess the efficacy in DCI prevention. And another trial which is going on is KETA trial, ketamine for thrombolysis and acute ischemic stroke. It is designed to assess its neuroprotective effect. Primarily, what they're assessing is the reduction in infarct size following ketamine administration. The results are yet to be published. Another newer thing, anti-NMDA receptor encephalitis. Now, this is something which we came across once with that some popular celebrity, if you guys remember, the young Dangal girl. She was diagnosed with this anti-NMDA receptor encephalitis, and she was admitted at AIIMS, New Delhi, and there they had given this, and from there this thing came to my recognition. And on further research, so anti-NMDA receptor encephalitis, it has a role with ketamine treatment. Primarily, it's an autoimmune disorder. Production of antibodies are there against the NR1 and NR2 subunits of NMDA receptor. It presents with symptoms of psychosis, seizures, memory, cognitive deficits, altered sensorium, and movement disorders. Now, ketamine per se is an NMDA antagonist, and therefore to give it an anti-NMDA receptor encephalitis seems a little confounding. But then the possible explanation of benefits seen are complex pharmacological action of ketamine on NMDA receptor and the other receptor systems, which lead to some amount of therapeutic beneficial. Two case reports are there, not significant amount of studies are published on this, but both of them one targeted dyskinesia and other targeted status epilepticus, and they found improved results with both dyskinesia as well as status epilepticus. Depression. Ketamine is having a major comeback in treatment of psychiatric conditions like suicidal ideations and bipolar affective disorder. How does it work? So ketamine causes indirect activation of AMPA receptor in the limbic system, which leads to the activation of mTOR pathways and upregulation of brain-derived neurotrophic factor. It produces changes in the synaptic plasticity, and which ultimately leads to increased synaptogenesis and synaptic potentiation in limbic system. So the advantage of ketamine over antidepressants, other antidepressants which are available is its rapid onset and prolonged duration of action. It bypasses the serotonin pathway. It directly leads to increased glutamate levels in the brain, and the doses which have been used in various literature is 0.5 to 1 mg per kg. Similarly, in bipolar affective disorder, now these patients, they have a high rate of suicide, approximately 6%. So ketamine has potent antidepressant and anti-suicidal effect, again owing to its NMDA inhibition and increased glutamate levels. In acute pain, now ketamine is an excellent analgesic. We have always known that mechanism of action. More light has been shed into its role with non-competitive antagonism of NMDA, most abundantly available receptor in the CNS. It's opioid agonism with mu, delta, epsilon, and kappa receptors, with mu being the most predominant one, and interaction in monoaminergic receptors at the supraspinal sites. The keyword here would be at low doses, ketamine has an analgesic effect, while at high doses, it leads to anesthetic effect. So low dose ketamine is what we are interested in to treat acute pain. It is safe and effective. It is an alternative, or it can be used as an adjunct to opioids. It has an opioid sparing effect, and doses of less than 0.5 mg per kg overall have been reported to be not associated with significant side effects. In fact, there is a summary of consensus guidelines right now given by American Society of Anesthesia, American Association of Pain Medicine, and ASRA. So it's just a brief gist of what they have said. So sub-anesthetic intravenous ketamine, it can be used for severe post-operative pain. Can be indicated. While in the cases of procedures that are expected to have mild pain, they do not have any added benefit with ketamine infusion. It can be an adjunctive therapy for opioid dependent or tolerant patients. Perioperative analgesia, a bolus dose of less than 0.35 mg per kg and infusion rate of less than 1 mg per kg per hour in non-intensive care settings is what these societies have recommended. As a sole agent in patient-controlled analgesia, very limited evidence to recommend ketamine. Coming to chronic pain, so ketamine has found some benefit in chronic regional pain syndrome. Moderately certain evidence is there, but other than CRPS, no other condition has a documented evidence or recommendation by established societies. Intranasal ketamine for breakthrough pain, again, it has a moderate certainty evidence. Oral ketamine, these societies are saying, has a very high abuse potential and therefore should not be recommended or given in patients. And they have also very categorically stated that ketamine must be avoided in patients with severe or uncontrolled CVS disease, severe liver conditions, intracranial pressure where it is documented to be high, elevated intraocular pressure, pregnancy, and in underlying psychiatric conditions associated with psychosis. In these situations, the ketamine should not be used as a primary agent to control pain. Again, ketamine is an excellent bronchodilator that was well established. New evidence has come up. One such recommendation was done by Chest 2021 journal. The bronchodilation mechanism, new insight has come into it. Inhibition of mRNA overexpression, decreased cytokine production, reduction in macrophage, prevents the catecholamine uptake in the periphery, increases the free norepinephrine levels, and it has a more pronounced effect on beta-2 receptors. All these lead to bronchodilation. The dose administered to be 0.1 to 0.2 mg per kg, followed by 0.15 to 2.5 milligrams per kg per hour of infusion. Some other studies have come, fairly recent studies, and they all have shown that ketamine has a promise as a bronchodilator. Alcohol and heroin addiction. The possible mechanism in treating addiction which ketamine plays would be increasing the neuroplasticity and synaptogenesis through the mTOR mechanism pathway, antidepressant effect of it, the stopping the reconsolidation of memory, and enhancing the efficiency of ongoing therapy. And ketamine plays a role in addict patients. High-dose ketamine psychotherapy with 2 mg per kg, it induces a higher rate of abstinence, it reduces the heroin craving, and greater alterations in non-verbal, unconscious, and emotional standpoints. So these are the few beneficial effects in the newer settings which we have. But then having said that, we should always discuss the adverse effects of ketamine, which is very important to administer as a clinician for us. So NMDA receptor blocking action, it may trigger an excessive release of glutamate, which causes cortical excitability and which in turn lead to psychotic behavior and cognitive abnormalities. This also has been associated with a neuroapoptotic response. So ketamine-related NMDA receptor blockade involves BCL2-like protein 4 Bax protein translocation to mitochondrial membranes, which leads to cytochrome C efflux, caspase 3 activation, and thus that plays a role in neuroapoptosis. Small gist of adverse effects in various systems. For cardiac system, it is ventricular myocardial apoptosis, fibrosis, sympathetic denervation, and development of cardiac arrhythmia. While in CNS, it is cognitive abnormalities, psychotic behavior, vivid dreams, hallucinations, emergence. Renal system, increased urinary frequency, urgency, dysuria. While in hepatobiliary system, it has been found to be associated with increase in liver enzymes or dilatation of bile ducts. Ketamine has an extensive drug interaction list, which is mostly theoretical to be precise. So coming to the conclusion, so what would be the take-home message? So whether ketamine is seasonal or regular. So frankly, It is an individual decision. It is definitely not seasonal, but to recommend it as a regular drug, it has to be individual specific and condition specific. It's a fascinating agent. It has a pleiotropic action on multiple receptor systems, and it has a widespread role in various other conditions like migraine, epilepsy, depression. But cautious and monitored use is warranted, and more RCTs regarding its use is required and the need of the hour. Thank you.
Thank you, Dr. Deep Sen Gupta, for bringing out again the pros and cons of ketamine. Very wonderfully pointed out all the recent evidences. And ladies and gentlemen, let me uh, tell you that if there is any drug that has bounced back in the world of anesthesia or neuroanesthesia, it is ketamine. The conventional teaching that ketamine increases ICP, over the last decade there has been multiple studies, good number of systematic review and meta-analysis which are saying that ketamine does not increase intracranial pressure both in traumatic as well as non-traumatic neurologically injured patients. So it's being used now almost probably in every neurointensive centers across the country, abroad. Particularly its use in status epilepticus and refractory status epilepticus, as well as in multiple other conditions which Dr. Deep has mentioned. We'll get back to you with queries. You can have a look at the chat box. Meanwhile, we'll keep updating you. It's now time to invite our final speaker, but not the least, Dr. Kanchan Bilji. She is a consultant neuroanesthesiologist in Chinmaya Mission Hospital, Bangalore, a former DM from NIMHANS, Bengaluru. Her key areas of interest are EEG and ultrasound in neuroanesthesia and neurocritical care. So over to you, Dr. Kanchan Bilji, for your talk on balanced salt solutions versus normal saline. Which one fares better in neurologically injured patients?
Thank you. Thank you for the kind introduction. And I thank the organizers for inviting me. I thank you, Dr. Ankur, for getting in touch with me, Dr. Malhotra, Dr. Katikar, Dr. Harshsapri. Thank you so much for this opportunity. Let me begin by sharing my screen. I also thank the participants for continuing to stay online. Let me just share my screen. Okay. Are you able to? Yeah.
Yeah, it's visible, Kanchan.
Okay. Yes. So let us continue the controversies in neurocritical care. Of course, areas of interest are EEG and ultrasound and all of that, but we cannot escape IV fluids. The complex nature of it haunts us every day in the OT and the ICU and also in the emergency department. So, but let's take it head on. Normal saline versus balanced salt solution. What is the resuscitation fluid of choice? What is the maintenance fluid of choice? So let us argue it out here. So really, what is the debate about? What are the arguments supporting normal saline and what are the arguments against the use of normal saline? So we will come to some conclusion at the end of this discussion, that I assure you, with a better understanding of the physiological behavior of these fluids and why traumatic brain injury patients are special. So what are the arguments supporting the use of normal saline? Well, normal saline has a very robust history. everyone has been using it, so much so that they started calling it normal saline. Now it is very rhetorically said everywhere that normal saline is not normal, and everyone likes to say that, but everyone has maximum experience only with normal saline. So it is not going anywhere, it is staying. Then also really there are not enough robust normal saline studies, so not enough RCTs that are able to oppose normal saline. So market driven or not, that is a different point, but very little convincing evidence is available to say that normal saline kills. And it is an effective resuscitation fluid, whether you like it or not. Sodium and chloride, they stay in the extracellular fluid space. So they stay in the intravascular compartment, which is very relevant during resuscitation. That is where we want the fluid to be. We want organ perfusion, we want renal perfusion, we want to prevent anaerobic metabolism. So really it serves that purpose. So it is an effective resuscitation fluid. There is a lot of talk about the normal anion gap acidosis that happens with normal saline. But really, how many patients have kidneys that cannot handle that kind of acidosis? So that kind of acidosis that is produced by normal saline, it seems benign. First thing is that it might be causing significant acidosis when used only in large amounts in a short period of time, which doesn't allow the kidneys to compensate. We will come to the metabolic effects of normal saline and hyperchloremia. So acidosis, even though it does occur, it seems to be a benign problem. Most patients can handle it. And really the cost factor, normal saline is cheaper and it is also widely available. Whether the cost factor is significant or not is a different point. Many times it is institution specific. So it is us clinicians who decide whether Plasma-Lyte or normal saline should be available in plenty in our hospital or not. So at the end of this discussion, we should be able to make that decision. What are the arguments against using normal saline? Why would you not want to use it? So it causes normal anion gap, metabolic acidosis. We will describe that in a moment. So you already have critically ill patients who are likely to be acidotic. They don't have good baseline renal functions many times. So you don't want to burden them with extra acidosis. So as trauma patients and patients in sepsis, this includes traumatic brain injury patients, you really don't want them to get into this scary triad where already there is hypothermia, there's already acidosis, so and there's already coagulation disturbances. So you don't want that. Hyperchloremia independently, apart from causing acidosis, can also cause acute kidney injury. The increased chloride load to the kidneys can cause renal cortical hypoperfusion. So this leads to acute kidney injuries, and many times patients require new renal replacement therapy, which they did not have required otherwise. Hypertonic saline is known to have anti-inflammatory effects. However, normal saline seems to have pro-inflammatory effects, but most of these studies are done in animals. Human studies have not been so convincing. So this has not been studied very well. So, but we'll just keep that. Also, there have been negative effects noted on hemostasis. So some studies have noted that large volume resuscitation and excess chloride are responsible for failure of hemostatic mechanisms, and these patients require more blood transfusion. Nausea and vomiting has also been mentioned, but really it's not very convincing. There are several other causes of nausea and vomiting in traumatic brain injury patients. So, and also the cost, really balanced salt solution, how much does a bottle of Plasma-Lyte cost? Is the cost of balanced salt solution really prohibitive? If you were to use balanced salt solution and have lower incidence of acute kidney injury, lesser number of patients going on dialysis, then it should save costs. So in a system where balanced salt solution is not prohibitively expensive, balanced salt solution is unique. So let us see what makes it unique, what makes it stand out. This is just for anybody who might have slept off because this is the last lecture. Please wake up. So let us compare the fluids that we have. We cannot escape this chart. So we have plasma with a pH of 7.4, and then all the other solutions except plasma light are at least mildly acidic. Out of all the other solutions, the cheaper solution, which is still balanced, is lactated Ringer solution or Ringer lactate, which is slightly different from what is known as Hartmann's solution, but most of the time they are synonymous. The sodium content in each of these is different. And this also overall affects the osmolarity, the sodium and the chloride content. So we can see that the normal saline contains 154 milliequivalents of sodium as well as chloride. So what is important to note here is that the normal plasma sodium is around 140. Normal saline contains 154 milliequivalents of sodium. It's not very different, just 10 milliequivalents different. However, the difference in chloride is stark. Normal chloride is around 100 milliequivalents per liter in the blood, in the plasma, whereas suddenly you're infusing 154 milliequivalents per liter of chloride. Now that is a big jump. That is a lot for the body to handle. That is why hyperchloremia becomes a problem. And then normal saline does not contain anything else. So this chloride is going to go and it's going to replace the bicarbonate. Bicarbonate is going to move intracellularly because there is so much of chloride in the body, and that has to be equalized. The number of negative ions in the plasma is now more of chloride and less of bicarbonate, which has now moved intracellularly because of this chloride. So there is nothing else that is going to provide the bicarbonate. So whereas if you have a fluid like plasma light, you're going to have acetate, you're going to have gluconate, and then if you give RL, which is one of the cheaper balanced salt solutions, you're going to give lactate. All these are bicarbonate precursors. We'll just see that shortly. So, which is why you can see that even looking at the osmolarity, plasma osmolarity is say roughly around 285. So plasma light A is great. It's 294. Ringer lactate also sort of hypotonic, and Hartmann solution 280, which is great. And normal saline is 308, much more than the normal plasma osmolarity. So when you have hypotonic solutions, this becomes significant in terms of osmolarity in traumatic brain injury patients. You do not want to give hypotonic solutions to an edematous brain. So that is when the debate between normal saline and RL or plasma light becomes significant in TBI patients. So it leads to what is known as NAGMA, the normal saline, non-anion gap metabolic acidosis. So what does chloride have to do with this? So as we saw, chloride is being pumped into the body at 154 milliequivalents per liter. So thus there's a disproportionate increase in chloride. So what is going to happen? The bicarbonate is going to move into the cell, intracellular space, so a chloride can be the predominant negative ion in the plasma. But what's happening here? Bicarbonate is a very important buffering agent in the body, and you're going to displace the bicarbonate, and there's not going to be enough bicarbonate available to buffer. So acidosis is just going to increase. So how is it normal anion gap? So sodium, potassium, and chloride and bicarbonate. So here chloride is going to increase disproportionately. So the anion gap is going to reduce. That is how you get a NAGMA. And also there is going to be a decrease in strong ion difference. Strong ion difference is again, it's different from anion gap because it also includes other unmeasured anions and cations. So you're going to also include calcium, magnesium. You're also going to include lactate, acetate, and gluconate and such ions. So that is going to reduce the strong ion difference, and this leads to what is known as acidosis again. So this is going to be a metabolic acidosis. Normally, if you would give it slowly, whether you give NS or balanced salt solution, the kidneys are able to compensate. There is this beautiful enzyme, carbonic anhydrase, which is present on both sides of the lumen in the kidney, and is able to handle the bicarbonate imbalance. But when you have a renal dysfunction, or when you're going to pump in so much chloride as a resuscitation fluid in a short time, body will not be able to replace enough bicarbonate. So, whereas if you give plasma light, you're going to provide some of those, and they're all going to become bicarbonate, and you will not have metabolic acidosis. So, for example, when you give Hartmann solution, ringer lactate, or you give plasma light, what happens to the lactate? The lactate becomes eventually bicarbonate. So, main place where this lactate gets metabolized is the liver. So 70 to 80% of the lactate undergoes gluconeogenesis and becomes glucose, and which again gets metabolized. And then you have oxidation also, which handles the lactate. So this is how plasma light makes sure that there is enough bicarbonate available in the system. So now let us just look at the studies. So there was one study by Semler et al., which was published in the NEJM in 2018. So they studied, it's a very large study, multi-center study in Vanderbilt University in Tennessee. 15,802 patients were randomized to receive either balanced salt solution or a saline. This was in generally critical ill patients, adults. So they saw that balanced salt solution resulted in lower all-cause mortality. But look at the p-value, lower incidence of new renal replacement therapy, and then lower persistent renal dysfunction. Okay, some mortality benefit, definitely. Also, we also have to look, if you delve deeper into the studies, the endpoints that they have used, and whether they have used only mortality or whether they have used a composite model to define the outcome. All these are small nitty-gritties of the studies, but if you go nitpicking, you'll really find a lot. But what we use clinically determines the outcome. Let's bear that in mind. And mind you, these are all generally critically ill patients. It's a mixed cohort. Balanced crystalloids versus saline in critically ill adults. So this was an RCT by Semler, but the next study in 2022, which was published in NEJM again, by Hammond et al., was a systematic review with meta-analysis. We know that these are better studies. So 13 RCTs comprising 35,884 participants. And really, how much of a mortality benefit do we see here? Everything is close to this odds ratio or risk ratio of 1. So it's mild mortality benefit that you can see, but any mortality benefit is great, whether it is clinically significant. And that is how the study was presented. This is one study, why go abroad? This is one study from Banaras Hindu University, BHU, by Shefali et al. And here they studied traumatic brain injury patients, where they admitted them, and then for maintenance fluid, they used either balanced salt solution or normal saline. And for anti-edema, they used mannitol. First 3 days, they also used furosemide, which is again controversial, but anyway. So they used mannitol in all the patients for reducing the ICP. The balanced salt solution caused lesser alterations in acid-base balance. They did the ABGs every day, they did electrolytes every day, and they found that it caused lesser alterations in acid-base and electrolyte status than normal saline, this balanced salt solution, and it is associated with more favorable outcomes. So mortality was 54% in the NS group and only 40% in balanced salt solution group. Okay, so they found balanced salt solution to be better in TBI patients. Then came in 2025, recently, in January 20th, 2025, in analgesia and anesthesia analgesia, in the critical care section, we saw this study, effect of treatment with balanced crystalloids versus normal saline on the mortality of critically ill patients with and without traumatic brain injury. It's a systematic review and meta-analysis by Jose et al. And here they said that the odds ratio for mortality in patients with TBI was 1.31. So, in patients who received balanced salt solution, and they said that normal saline actually had a mortality benefit. So, patients with balanced salt solution were likely to be 1.3 times more likely to die than if they had received normal saline. So the secondary outcome included length of hospital stay, renal complications, need for vasopressors or mechanical ventilations, and mortality in critically ill patients with sepsis in this TBI cohort. And they found that there was no difference really in any of these secondary outcomes also. So mortality benefit was seen with normal saline in TBI patients. Subgroup analysis of TBI patients enrolled in the SMART trial, the isotonic solutions and major adverse renal event study. TBI patients assigned to the balanced crystalloid and saline were studied in this subgroup analysis. Only the TBI patients were selected, and NS and balanced salt solution were compared. And patients in the balanced crystalloid group were more likely to be dead or to be discharged to another medical facility because of not being well by a factor of 1.3. So their associated odd ratio was around 1.38, and with a slightly statistically significant p-value. So really, what's going on here? Why are TBI patients different from other critically ill patients? So these patients have to be studied separately because the lower tonicity of balanced crystalloids, as we saw around 270 or 280, can be their osmolarity of these maintenance fluids. And what we want to give patients is hypertonic fluids in TBI. So this could worsen the cerebral edema in patients with intracranial pathologies like the one seen on the slide, when you have a severe traumatic brain injury with so much of edema, midline shift. This will all lead to secondary brain injury if the edema worsens. So that is the first thing that we are trying to prevent in a neurocritical care unit. And also, we know that over time, when you give balanced salt solutions, eventually that lactate acetate gluconate is going to become bicarbonate, and these patients are likely to become alkalotic. Many times, traumatic brain injury patients are themselves spontaneously hyperventilating, and you see respiratory alkalosis. So what happens when you give them balanced salt solutions also, which are going to cause metabolic alkalosis? So alkalosis itself is not something that is benign. So the risk factors for acidosis with NS, that is also there. Why is NS incriminated so much? Because it causes acidosis. And balanced salt solutions are not innocent. They can also cause alkalosis, especially in a setting of hyperventilation where you already have alkalosis because of other causes. Rapid infusion of large volumes of NS, critically ill patients already in metabolic acidosis, you don't want to give NS to them. But balanced salt solutions are not benign either. So really, you have to choose the patients, and you don't have to use only balanced salt solutions. We can always use a combination of both, and see if we can monitor the electrolytes more closely, monitor the pH status of the patient closely, keep a watch on the renal function, and allow mannitol, a hypertonic saline, to account for those adjustments as well, and just allow balanced salt solution and normal saline to do their jobs, knowing very well their limitations. So this was my presentation on this topic. I tried to make it as simple as possible. So open to questions. Thank you.
Thank you so much, Dr. Kanchan. Very, very nice presentations, bringing out all the scientific evidences, particularly in neuroanesthesia as well as non-neurologically injured critically ill patients. Of course, the evidence is drifting towards balanced salt solutions when it comes to critically injured patients, but as you pointed out, in traumatic brain injury, the evidence is still on a balanced side.
Yeah.
Thank you so much, Dr. Kanchan. May I now invite Dr. Manisha Katikar madam to speak on the presentations, and then we can begin the discussions. Manisha ma'am. Manisha ma'am, are you there? Can you unmute? Ma'am, kindly unmute, ma'am. Not able to. Okay.
Dr. Ankur, please stop sharing.
Yeah.
Dr. Kanchan, please stop sharing.
Yeah. Good evening, sir.
Yeah, now I'm able to unmute myself.
Yeah, ma'am, you are audible.
Yeah. I must say it was a wonderful presentation. The topic chosen was excellent. I think the topic, all the 4 topics that has been chosen for the discussion related to controversies in neuroanesthesia, all the topics were excellent. And all the speakers, Dr. Kaustav, Dr. Sangeeta, Dr. Deep, Dr. Kanchan, all of them spoke so well, telling us about all the clinical trials, the relevance in today's anesthesia practices, considering different clinical scenarios. So extremely happy with all the speakers as well as even the moderator also, Dr. Ankur, that he has chalked out all the topics so well and the speakers have done justice to the presentations. So I'm extremely happy. And if you consider the first topic, that is nitrous oxide, still yes or no? I echo the feelings of Dr. Sangeeta. Yes, there are multiple studies now which indicate that nitrous oxide has various side effects. And when we have multiple n number of good drugs like dexmedetomidine, she mentioned about dexmedetomidine, dexamethasone. I would also like to say about remifentanil, fentanyl infusion. So we have n number of drugs, good drugs. Then definitely the time has definitely come to stop using nitrous oxide in neuroanesthesia. So it was, Dr. Sangeeta, wonderful presentation by you, and all those studies, the Enigma studies, trial 1, trial 2, then the post hoc analysis, though the effect on the hospital stay or maybe the long-term mortality or morbidity with the use of nitrous oxide is not affected, but still the intraoperative course definitely matters. But when we are not using nitrous oxide, we have to be very careful about avoiding awareness. So we have good number of drugs and we should start using them and start avoiding nitrous oxide in the anesthesia practice. So that is my view on nitrous oxide. The second topic I think was ketamine in neuroanesthesia. No. It was mannitol versus hypertonic saline by Dr. Kaustav. He presented the second topic. I agree with you, Dr. Kaustav, that definitely mannitol has some disadvantages as compared to hypertonic saline. But my opinion is still that the optimal choice regarding the use of mannitol or hypertonic saline will depend on specific clinical situation. There were questions in the chat box. Somebody had asked that I'll start mannitol at the beginning of surgery and will stop mannitol once the dura is open. And when should I stop then the hypertonic saline? So it is not mandatory that you have to use both these drugs intraoperatively to reduce the brain edema. Whatever you are practicing, you can use both the drugs together. At the same time, you must know the disadvantages of mannitol and advantages of hypertonic saline over mannitol. And you must specify or you must specifically choose the anti-edema measures considering the individual clinical scenario. So that is my take on this, Dr. Kaustav, and he nicely demonstrated all clinical trials and all studies.
Thank you.
The third was, I think, the third topic was ketamine in neuroanesthesia by Dr. Deep. Yeah, Dr. Deep, you presented extremely well. It was so nice to listen to the history and then about the resurgence of ketamine. And you explained so well about the use in medically refractory migraine, then resistant status epilepticus and so on. So we have started using definitely ketamine in neuroanesthesia, more in neurocritical care. So I recommend using, and there are n number of studies about the use of ketamine in depression, use of ketamine in status epilepticus. In fact, the refractory status epilepticus as a 3-trial drug. So we are using, few of us have used ketamine in refractory status epilepticus, and your presentation was too good. So still the query whether it is seasonal and regular, my opinion will be, it should be not regular still, but
depending upon the indication that has been extremely well, Dr. Deep spoke extremely well on those recommendations, so it should be used. And another thing what I would like to mention here is that we have to look at the doses of ketamine. Most of the indications what Dr. Deep has mentioned, they have sub-anesthetic doses. So that has to be kept in mind when we are using ketamine for indicated specific indications. And the fourth was, yes, by Dr. Kanchal, normal saline versus balanced salt solution. Extremely good presentation. And I was so happy to read about or to listen to the physiology and the effects of all these IV fluids on various electrolytes, the kidneys and the other systems. I still feel that I'm seeing use of this balanced salt solutions so commonly nowadays in many of the hospitals. I still feel that maybe I'm an old practitioner. So as you mentioned, ringer lactate, I'm still happy with ringer lactate. And my personal opinion about use of balanced salt solution in neural anesthesia, especially for resuscitation in trauma patients. So that is what I can say. Maybe in resuscitation or maybe in resuscitation of septic patients with sepsis, we can use balanced salt solution. As far as neuroanesthesia is concerned, the use of balanced salt solution, even if you read Miller, 9th edition, I haven't read 10th edition, but in 9th edition, they have mentioned in the chapter in the anesthesia for the anesthetic management of various neurosurgical procedures, they have mentioned use of ringer lactate as well as normal saline alternatively in patients who are undergoing neurosurgery. So still the textbooks have not included use of balanced salt solutions. So again, it should be your individual decision. It should be your hospital policy. What I'll say, because it is only that solution is made available sometimes in the OT. And I am an old practitioner who still feels that ringer lactate is as good as the balanced salt solution. So my take on all the talks, excellent presentation, and all of them presented wonderfully.
Thank you, Manisha ma'am.
Thank you,
Thank you
ma'am.
so much. You have summarized 1 hour talk in just 10 minutes. All the important points you have highlighted very well. And thank you so much, ma'am. Now the meeting is open for discussion. Our senior faculty members, anyone who has opinion, a different opinion, please kindly unmute and you can have your queries. The webinar is open for discussion.
Okay, Dr. Ankur, a very
ma'am.
comprehensive handling of the controversies. So I think we are overshooting the time. So just to conclude, because let's see whether we have resolved the controversies or not. So let's take them one by one and hear from the speakers only, because they have researched both the aspects. So Dr. Sangeeta, nitrous, yay or nay?
As of now, no. I
No.
think we need more robust evidence to prove its safety profile when compared to the relatively safer alternatives that we have
So
access
just
to.
to know, how's the nitrous oxide supply at NIMHANS? Because at our
Yeah.
center, we have discontinued pipeline and just SOS use. If anyone needs, we have small cylinders. Otherwise, we have stopped the supply through pipeline. So how's it at NIMHANS?
We still have access to nitrous oxide, but then our decision to use it depends on our individual take on whether it's safe for the patient or not.
Right. Excellent. And for the next, it was ketamine, seasonal or regular. So, Dr. Deep, are you a regular user yourself?
So, ma'am, so regarding ketamine, I must say Dr. Manisha ma'am has wonderfully summarized it. The take-home message is this: with all the recent evidence, it is the low-dose ketamine or sub-anesthetic doses of ketamine which has made a comeback and which can be used in myriad of situations. From neuroanesthesia point of view, we are regularly using it to increase our motor evoke potentials, ma'am, during neuromonitoring. For procedural sedation and all, and in neurocritical care setting, yes, we have started using ketamine. Low dose sub-anesthetic doses, we are definitely using, ma'am, yes.
Yeah, it was a very nice presentation on that. Dr.
Thank
Costa, yours was also an excellent presentation. So you told like where to use mannitol and where to use hypertonic saline. Suppose there is a clinical scenario wherein we can use any of these. So what will you use?
Ma'am, I would prefer hypertonic saline if given a chance. I think it works well, and we can use it for a prolonged period of time. And specifically the aspects on renal injury, I've seen that most of our patients they develop some kind of a renal issue. So in those patients, I can safely use hypertonic saline. However, having said that, mannitol is still being used. Some of the neurosurgeons they still use it in our neurocritical care unit. But then for infusions and maintenance, we use 3% saline.
How about an impromptu poll? If all the participants can write mannitol or hypertonic saline, what they prefer if both can be used in a clinical scenario. Just quick type maybe hypertonic HS and mannitol. And then Dr. Kanchan, excellent presentation, I must say. Madam had Dr. Manisha Khatikar, madam had already summarized your talk that how she uses it. And do you use balanced salt solution in all the scenarios yourself in your practice?
Thank you, ma'am. No, I don't have access to plasma light in my current institution, but we used to use it very selectively in my previous hospital also, where we had it. And reason was it was not available, or they thought it was costly and all of that. But we were managing very well with NS and RL, and those were not the fluids which were concerning for us. We are using so many hypertonic agents and other drugs and other clinical scenarios which are more problematic. So when these studies are done in critically ill patients also, there are so many factors which lead to the patient being sick. And it is not the maintenance fluid alone which leads to adverse events.
Yeah, thank you so much. Yeah, thank you. Dr. Ankur, I think there are no further questions, and you have written both, but many have written mannitol. So I think the controversy still remains, or change of hearts is still required. Okay, so if there's no further questions, I request you to close the session and comments, closing remarks from Dr. Nabil Malhotra sir as well, President RSA.
Thank you, Dr. Swati madam. Finally, we have come to the end of the sessions. I express my heartfelt gratitude to all the 4 speakers who are dear friends. Thank you for accepting the invitation on behalf of RSACP and putting forth such brilliant presentations with take-home messages. Especially Manisha madam for sparing your valuable time and contributing so much with those summaries. Thank you once again. And nonetheless, the participants who stuck in there with almost till 7:45, we are still having so many participants. Thank you so much. I'm sure you must have all been benefited with this presentations. We'll come up with more and more presentations in future. We assure you that on behalf of RSACP. I now invite Dr. Naveen sir for your closing remarks, sir.
Thank you to everyone. The moderators, the organizers, the chairpersons, and the speakers. And as a president, I'm happy that Research Society of Anesthesiology is actively involved in the academic program. Resume for the neuroanesthesia part 2 after 15 days. Thank you very much.
Thank you so much.
Thank you,
you
sir.
everyone.
Thank you.
Good night.
Thank you,
Thank
sir.
you, everyone.
Thank you.
Thank you,
For
everyone.
being here. Thank you,
ma'am.
moderators, chairperson, and speakers. With your permission, sir, we'll close the webinar now.
Thank
Thank
you
Thank
very
you,
much.
Naveen sir.
Thank you all.
Thank
Thank
you,
you.
Ankur.